Um, this is the pain management adult version of the protocol. Some pretty significant changes to this. I'm pretty excited about it. Hope you guys are too. For you EMTs out there, just routine patient care, keep them in a position of comfort, reassure them, give them psychological support, distract them from the pain. Um, if you need to, use pain padding along any immobilization devices or when splinting, fractures, or dislocations. Make sure you elevate the injured extremities if possible. You can consider applying a cold pack for about 30 minutes. Make sure you have the patient do a pain scale. So ask them if their pain, what their pain is on a scale of 1 to 10, where 0 is no pain at all and 10 is the worst pain ever. And then reassess that pain scale every 5 minutes or so. Try not to coach them into giving you an answer. Just say that verbatim. What is your pain on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain ever? If they can't answer that, use the Wong-Baker face scale and consider ALS Intercept for pain management if needed. You can also, for mild to moderate pain, so pain less than 6 or less on the pain scale, if they're able to take oral medication, you can administer ibuprofen 400 to 800 milligrams PO once, or you can give Tylenol 500 to 1,000 milligrams PO for one dose. Advanced CMTs, you guys are going to IV access, administer fluids to maintain a MAP greater than 65, and for treatment for moderate to severe pain, so greater than 5 out of 10 in patients with a GCS greater than 13. You can do ketorolac, or Toradol is what most of us call it, 15 milligrams IV push or 30 milligram IM, and that's one dose. You can't give a repeat dose. You can consider Toradol as the first line treatment in renal colic. So if you think they might have like a kidney stone, Toradol usually works better for those patients. Reason being is opiates typically cause like um, a spasm around the stone, so it actually starts hurting worse. Make sure you avoid Toradol in patients going to the OR, patients who have an NSAID allergy, aspirin-sensitive asthma, known peptic ulcer disease, or if they're pregnant or nursing. I want to put a heavy emphasis on patients that might have a possibility of going to the OR. So any patient with abdominal pain or any patient that has suffered trauma, they have the potential to go to the OR, so do not give them Toradol. NSAIDs kind of thin the blood, so that's kind of the reasoning. Next option is morphine, 4 to 8 milligrams IV IM every 10 minutes to a total of 15 milligrams. You titrate it to pain and make sure they have a systolic of greater than 90. And third option is going to be fentanyl, 0.5 to 1 mic per kilogram, slow IV push, intramuscular or intranasal. Your max single dose is going to be 100 mics. You can give that every 5 minutes up to a total of 200 micrograms of fentanyl. We don't carry nitrous oxide, so we'll kind of skip that. I do want to point out one thing here. These doses are a little bit different than doses listed in other specific pain protocols. So like talking like the chest pain protocol, or it's called the acute coronary syndrome protocol, but that one, or the abdominal pain protocol, they're a little bit different. Like we just talked about the abdominal pain, and it's a max of 10 milligrams of morphine. So just keep that in mind when you're treating them, that different protocols have specific um, max dosages. So uh, just keep that in mind when you're treating those specific complaints, okay? Um, I know advanced CMTs, you guys were given Toradol before here at Ambulance Inc. I do want to go over Toradol, morphine, and fentanyl with you guys, though, a little more in depth so that maybe you'll feel a little bit more comfortable giving it. So, ketorolac, or also known as Toradol, is a non-steroidal anti-inflammatory drug, or an NSAID. It's also an analgesic, which means pain management. So if you ever see in a protocol it says analgesia, that's what it means. It means pain management. So Toradol works as an NSAID. It blocks the prostaglandin complex formation and production. So what prostaglandin is it's a lipid that your body has that it releases when it's trying to fight off some kind of infection or some kind of pain, and it triggers inflammation. So that inflammation is actually what is making your body hurt and giving that pain signal. So without the prostaglandin there, it kind of relieves the pain because there is no inflammation, right? So that's kind of how Toradol works. It is a potent analgesic that does not possess any sedative or anxiolytic activities. Its indications are short-term pain relief. Contraindications include pain relief prior to major surgery, allergy to Toradol, if they're at risk for bleeding, stroke suspected or confirmed, or an aspirin allergy. Some adverse reactions from Toradol may include bleeding or rash. Some interactions include avoid using it with other NSAIDs and don't use it in conjunction with Lasix either. So if they're on Lasix, don't give it to them. The reason being, it's just kind of hard on your kidneys. Toradol comes in 30 milligram per ml vials. That's what we carry here at Ambulance Inc. Its dosage, like we said just now, is 15 milligrams IV push or 30 milligrams IM. So some special considerations with it is its pregnancy safety rating is a category C, meaning the risk of it cannot be ruled out. So use caution giving it to pregnant people. Actually, I wouldn't give it to pregnant people at all. The protocol says even to avoid it in pregnant patients or those who are breastfeeding. Avoid it in patients with a history of aspirin or NSAID, or avoid with a history of aspirin or NSAID drug. It increases the risk of bleeding, therefore do not use it in a patient that may need to go to surgery. Morphine is an opioid analgesic. It alleviates pain through CNS actions. It actually works on opiate receptors and kind of blocks the way the brain sends pain signals to the rest of your body. So it kind of suppresses fear and anxiety like that as well. It also depresses the respiratory centers in the brainstem. It increases peripheral venous capacitance and decreases venous return. It also decreases preload and afterload, and therefore decreases myocardial oxygen demand. It's kind of one of the reasons they like to give it during chest pains, although there's some conflicting research on that. So indications, analgesia for moderate to severe acute and chronic pain, and chest pain associated with an acute MI. Contraindications include a head injury, exacerbated COPD, depressed respiratory drive, and decreased level of consciousness. Suspected hypovolemia, or patients who take MAOIs within the past 2 weeks. Adverse reactions include respiratory depression, hypotension, decreased LOC, nausea, vomiting, bradycardia, tachycardia, syncope, facial flushing, euphoria, bronchospasm, and dry mouth. A little typo there, sorry about that. Drug interactions include it potentiates the sedative effects of phenothiazines. MAOIs may cause paradoxical excitation. And dosage is going to be 48 milligrams IV IM every 10 minutes to a max of 15. And for the pediatric patient, it's going to be 0.1 milligram per kilogram IM every 10 minutes to a max of 15 milligrams. Its onset is immediate. You're going to see the peak effects within 20 minutes, and the effects of morphine last about 2 to 7 hours. Again, pregnancy safety category C, so I wouldn't really give it to them if they're pregnant. You should have Narcan available if you're going to be given these kinds of medicines, and I highly encourage you to monitor respirations with the end-tidal CO2 waveform. It gives you a live respiratory rate, and you can watch if your patient begins to hypoventilate or become apneic. You can see it on the monitor, and it's documented when. Fentanyl is also opioid analgesic. It's a Schedule II drug. It works through similar mechanisms of action that morphine does. It alleviates pain through acting on opiate receptors, blocking the way the brain sends pain signals through the body. It also depresses respirations, suppresses anxiety, but it has less histamine release than morphine. So probably not going to dilate your blood vessels as much as morphine does. Indications include analgesia for moderate to severe pain. Contraindications include allergy to fentanyl, if they already have a depressed respiratory drive, or if they have a head injury. Some adverse reactions include respiratory depression, hypotension, decreased LOC, nausea and vomiting. And the dosage for both adults and peds is going to be 0.5 to 1 mic per kilogram. Max single dose of 100 mics. You can give that IV, IM, intranasal every 5 minutes to a max of 200 mics. Pharmacokinetics onset is immediate. You're going to see peak effects within 3 to 5 minutes, and it's going to last about 1 to 2 hours. Again, it's pregnancy safety category C, so it's kind of the risk is unknown. So I would just be cautious and not give it to pregnant patients. Also, you want to use this with caution the geriatric population or any patient with respiratory depression or hypovolemia. Paramedics, if a patient does not respond or the pain is not relieved by the opiates listed in the advanced EMT protocol, or they have an allergy or intolerance to opiates, you can consider 0.15 milligram per kilogram IV slow of ketamine. So if you do this, when we get the ketamine, it's on back order until November right now. If when we get it, you do end up giving ketamine, you want to dilute this dose in a 100 milliliter bag of normal saline and run it over about 10 minutes. Alternatively, you can dilute the dose in a syringe of 10 mLs and administer that over 5 to 10 minutes. You can repeat this dose once if pain remains and the pain scale is greater than a 6 out of 10 and mental status is preserved. Okay. For hyperventilation from opiate administration by EMS, you can administer Narcan 0.4 milligrams IV as needed. If they become nauseous, refer to a nausea protocol. A lot of times I'll just go ahead and give Zofran with the pain meds I give, just because I've seen people get nauseous and sick to the stomach way too many times. And I just go ahead and give it, so we kind of prevent that. Ketamine is weight-based on ideal body weight as well, so it's not regular weight, it's ideal body weight, so that's based on their height. So just keep that in mind when you're giving ketamine. And then if you need to, contact Med-Control for guidance with patients with an altered mental status or multi-system trauma, or for requests of additional doses. Okay. Paramedics, I just want to go over ketamine real quick with you guys. So it's a dissociative agent and analgesic. Kind of the way it works is it's a NMDA antagonist. So it causes analgesia at low doses and sedation at higher doses, which I think is kind of interesting. It's kind of a 2-for-1 drug. But basically being an NMDA antagonist kind of is like the same thing with morphine and fentanyl, except it's a different receptor it works on. It kind of blocks the pain receptors from receiving the pain signals from the brain. So indications, analgesia refractory to other means of pain control, post-intubation analgesic sedation, so you kind of use it for sedation and analgesia, and sedation for severe and dangerous agitation and excited delirium. Like we talked about the agitated patient protocol. Contraindications include acute coronary syndrome. It may increase intraocular pressure. Patients with underlying conditions in which increased blood pressure would pose a risk, such as aortic dissection, uncontrolled hypertension, myocardial infarction, or an aneurysm. All that stuff you want to kind of use caution. You don't want to give ketamine to at all, actually. It's contraindicated in a patient who has schizophrenia due to the potential excitation. It's not recommended in OB patients, and you kind of want to use caution in a patient who's intoxicated with ethanol due to the added sedative effects. Ketamine can interact with other medicines that may cause sedation or increase the blood pressure. As far as dosing, for pain, it's going to be 0.1 to 0.3 milligram per kilogram over 2 minutes. That's what the medication list in the Cavendish protocol says. What the actual Cavendish protocol says is 0.15 milligram per kilogram ideal body weight over 10 minutes. So keep that in mind. Post-intubation sedation is going to be 0.3 to 1 milligram per kilogram hour infusion, or you can do 0.1 to 0.5 milligram per kilogram IV bolus every 30 minutes. And then severe agitation is 4 to 6 milligrams per kilogram IM. And all that is ideal body weight, not regular body weight. Duration of action includes 10 to 20 minutes IV or 20 to 30 minutes IM. Make sure you're monitoring these patients with continuous SpO2, cardiac, and waveform end-tidal CO2 monitoring. Okay.